I've been studying at the University of Toronto at the Atlanta School of Public Health in their Social and Behavioral Health Sciences program. And this has been my project over the last couple of years that I've been focusing on. So as Ron mentioned, I looked at a regulatory standard in the province, and my dissertation had different components. So today I'm just going to be focusing on some of the insights that came out of the case study work that I did, and also showing you some injury trends as well that we looked at. So this was my fantastic thesis committee. I was supervised by Cameron Mustard here, as well as Curtis Breslin, Lynn Holness, and Catherine Nicol, a really great group. I was really quite lucky. And then I had, in the beginning, an idea to think about the value of having an advisory committee. I had done some pilot work and some preliminary interviews, and I thought it would be really great to have a committee with representation from these organizations at the proposal stage. And I got some really great advice on interview topics and groups of informants to speak to, and I thought that was a really, really great experience. I'd like to start out with an injury report. We're going to be talking about a regulatory standard designed to prevent needle-stick injuries, and I think it's important to understand the nature and the implications of this type of an injury, because it's a little bit different than other types of injuries that we think about in health and safety. So a hospitalized patient with AIDS became agitated and tried to remove the intravenous catheters in his arm. Several hospital staff members struggled to restrain the patient, and during the struggle, an IV infusion line was pulled, exposing the connector needle. So the nurse at the scene recovered the needle and was attempting to reinsert it when the patient kicked her arm, pushing the needle into the hand of a second nurse. So the nurse who sustained the needle stick injury did test negative for HIV that day, but she tested HIV positive several months later. So of course, this kind of a report emphasizes the underlying health consequence that we're talking about. It's not just a first aid kind of an injury, it's the potential health consequences if there is an exposure. But I picked this case report because I also think it emphasizes the unpredictable nature of working in healthcare. So we can make advances in training and work practice controls, but sometimes advances there are not really able to prevent some of these injuries that are happening. So that's what got thinking around how can then we actually engineer out the hazard. So in the mid to late 80s, some people got together to think about how can we redesign a needle to make it safer. So on the right here, we're looking at a needle you'll see quite often in hospitals. It's an example of a manual safety engineered needle where the safety component is basically flipping a cap over a needle for safer sharps disposal. We've also designed some other variations, what some people would consider to be more advanced safety devices. So this example, following injection, the needle will actually automatically retract into the barrel of the device with no user activation required. And people have referred to these kinds of devices as passive safety engineered needles. And then there's a slight variation too, where you might have a needle retract into a device with the push of a button. And people refer to those as semi-automatic because they're not fully passive. So in Ontario, we developed a regulatory standard to promote the uptake of these devices. Under our Occupational Health and Safety Act, it requires employers to make safety engineered needles available or to replace a hollow-bore needle with a needleless device. And this regulation came into effect in September of 2008, and it was established in 2007. So we regulated for a number of reasons. Of course, there was the burden. At one point, there was an estimate going around of around 33,000 needle stick injuries in the province. This is quite difficult to estimate. We also had, of course, about 20 pathogens have been reportedly transmitted via needle stick injury, and this includes HIV, hepatitis B, and hepatitis C. There was also the cost component. So the cost factors in when you're doing post-exposure treatment and testing. So typically this would be a baseline check 6 weeks, 3 months, 6 months post-exposure. And there was a solution. We had these safety engineered needles and medical sharps. But the problem was that the adoption of these devices by healthcare organizations was initially slow, in part due to the higher costs of SENS relative to conventional devices. So an important question that comes up is, how have needle stick injuries declined in Ontario? So I'm just going to be showing you some data from the WSIB, some compensation claims. I had a custom data request from the WSIB to look at needle stick injuries. So in part, this is lost time claims, but also the no lost time claims come from the PEER program, so the Program for Exposure Incident Reporting. And we're seeing a downward decline in needle stick injuries. So we're looking at the healthcare sector. If we compare the rate in 2004 to 2012, we're looking at a 26% decline. And a little bit too much volatility going down in lost time claims to really assess a trend there. So this is not a great data source to assess the magnitude of needle stick injuries, but it is helpful for looking at trends. And we have been able to confirm this trend and this magnitude of a downward decline in our work-related emergency department records. We can also look at rate group. So it's really the hospital sector where we're seeing that similar decline, around a 30% change between 2004 to 2012. Not much of a steep decline around the time of which the regulation was established. But we do see that in nursing care, so where you would have long-term care homes. Quite a dramatic drop in needle stick injuries, and we've seen a plateau. And then not much going on in nursing services. So this is where you would have home care workers. So it's important, I think, not only to talk about our needle stick injuries going down, but also the magnitude of the decline against what was expected from the system-level transition to safety engineered needles. So if you look back in the private members bill that was introduced, that introduced the Safe Needles, Safe Lives Act, some had the expectation that this kind of a transition could bring down needle stick injuries upwards of 80 to 90%. There was a hospital in Toronto that transitioned to safety engineered needles, and they published a case study, and they were able to see needle stick injuries drop by over 80%. In British Columbia, they set a measure of success as a 50% decline in needle stick injuries. So hospitals in Ontario haven't met that measure of success yet, but either has British Columbia at this point. So we conclude that for hospitals specifically, we've seen a trend, but the decline hasn't necessarily been substantial. So my dissertation focused more on implementation, and it was very much framed by thinking around implementation, because too often we're seeing these less than optimal impacts of system-level interventions with an absence of information to really contextualize unexpected or less than optimal results. And it's important to point out that Ontario's regulatory standard was designed to be flexible. How and what will be implemented is actually dependent on organizations, so that became my focus. So implementation science very much influenced the framing of my study. It's this new interdisciplinary field that identifies structures, supports, and conditions that promote the successful integration of new programs, innovations, and ideas into practice, like safety engineered needles. And we can think about it in terms of the chain of where research is falling. We have this design phase, so designing safety engineered needles. We've done some research and dissemination, like looking at guidelines and how they promote the uptake of evidence in healthcare. Also, regulation is a dissemination strategy. We've done research around adoption. How do you promote the adoption of a new idea or a program or technology in organizations? And we've done a lot of evaluative work that has looked at outcomes of interventions, but there's been less research around optimal implementation. And it's Dean Fixon at the National Implementation Research Network that's really leading this field And he put together this equation. It's really more of like a conceptual tool to communicate implementation science. And it's emphasizing if we want to get to positive outcomes, we need to think about effective innovations, but also effective implementation. So I have this conceptual framework that I have in my dissertation. I just wanted to put it up because I wanted to emphasize a couple of things that I might allude to in my results, and sharing some of my findings. One is that we think about implementation as actually a series of phases. So there's usually a planning stage, initial implementation, and a full operation stage where you might have ongoing monitoring and improvement. We've also been doing some thinking in the literature around how do you actually accomplish effective implementation? What does that mean? So it's been defined as consistent and quality use of an innovation. It tends to start out with obviously an organizational readiness for change. This tends to include management support, financial resource availability, but also change commitment and change efficacy. And then there's all these things that need to happen for successful implementation. You need comprehensive policies and practices. You need to have essentially an implementation climate where staff feel that the use of safety engineering needles is supported within the organization and expected. You have to have, it's always helpful to have an implementation champion, someone who's really pushing this forward. And also there's been some thinking around innovation values fit. So does this new program or technology fit with the values of staff and the organization? So I'm going to be sharing with you some of the insights that came out of the case study work. And the case study was an exploratory study that had a broad focus on looking at how the implementation process played out in acute care hospitals, how hospitals responded and managed the integration of these devices, consequences of integrating these devices into practice, and also looking at remaining issues. So I had 3 acute care hospitals, and my data included interviews and also review of documents. And at each hospital, I was interested in interviewing organizational informants as well as frontline workers. Organizational informants were people who could speak to the implementation of these devices, people who were involved in the transition. So this included occupational health and safety, reps from a Safer Needle Task Force, if there was one formed, the Joint Health and Safety Committee reps, purchasing and procurement, logistics, and professional practice. Interviews were carried out with registered nurses and registered practical nurses, primarily in emergency and critical care. And essentially these were individuals who were using safety engineered needles on a regular basis. So I was fortunate to have, at the 3 hospitals that ended up participating, a really comprehensive array of documentation that had been retained, which was really helpful. For example, of course, policies and procedures, injury statistics. I had some email correspondence, meeting minutes. There was even some Ministry of Labor orders that were relevant to look at. In terms of the interviews, there were 30 interviews carried out at the hospitals. I've broken it down here by primary informant category. Also, whether or not the participants had a health and safety role. So the majority did have some sort of health and safety role currently or in the past, because I was interested in interviewing people who had a role in the transition process. We saw, of course, more females in the sample because we are looking at healthcare. In terms of the time in the current organization, there were a number of participants that had more than 10 years of experience. And this was likely mostly influenced by an interest in speaking with people who were around during the transition, and also in interviewing hospital administrators who tend to have more experience. So this is sort of a range of the interview topics. So the topics, of course, would depend if I was talking with a frontline worker or a director of occupational health and safety. But there were some common topics addressed in all the interviews. And I just put a range of some of the examples. So, of course, I was looking at staff background, the types of devices currently in use. With frontline workers, we talked about injury experiences and impact of these devices on perceived injury risk. the staff response to the transition, implementation issues like reasons for ongoing injuries. A lot of the reviews of the documents helped inform an understanding of the implementation process, but this was addressed in interviews as well. So looking at the overall experience as well as facilitators, internal and external. And then I had a really specific interest in looking at ongoing implementation. So what are organizations continuing to do for needle stick injury prevention? So for the analysis, the initial analysis actually involved preparing interview summaries for the participants to review, just to really continue the exchange, to ask some follow-up questions, and it ended up being a really helpful process for this particular study. The analysis was an iterative process guided by data gathering and analysis. I did draw on implementation and organizational change theory. I used a systematic data coding procedure to help navigate the data. So I ended up with a lot of information for each hospital. I actually found it really helpful to have in vivo to really facilitate the within case and cross case analysis. And then my focus initially was on description and synthesis of this information to create case reports. So basically a story of how each hospital integrated these devices, which was followed by a thematic analysis. Now, I'm not going to share all of the findings today. I'm going to be focusing on two areas: conditions that supported and challenged the integration of these devices, and ongoing commitment to needle stick injury prevention. So one of the challenges I've had is that in preparing descriptive case reports, it actually makes it really difficult to put into a presentation. So I put this table. I'm just going to be talking about the three hospitals and then going into some examples and details later on. So I was very lucky. I actually ended up with three hospitals that transitioned at different time points and for different reasons. Some were externally motivated by the regulation or inspection order, whereas I had one hospital that was actually, they transitioned voluntarily. So Hospital A, I call the first hospital Hospital A for confidentiality purposes. They were a large teaching hospital. They did respond in 2007 after the regulation was announced, and they only had about a 9-month period to convert their entire stock of hollow bore needles. So that was quite a challenge for them. There wasn't really a lot going on prior to this point in terms of needle stick injury prevention. They integrated a mix of semi-automatic and manual safety needles. This particular hospital encountered a lot of implementation challenges in the rollout of these devices. I will go into more detail with respect to some of the challenges. They did observe a decline in needle stick injuries, so comparing the year prior to their transition to 2011, needle stick injuries had gone down around 28%. Hospital B was a multi-site community hospital. They had a very different experience in they transitioned before the regulation was established, but after a workplace inspection order. So there was a frontline worker at this hospital who was very passionate about health and safety. She was part of the Joint Health and Safety Committee and was continuing to make recommendations for safety engineered needles. And there was a bit of a conflict around this time period on their committee. She was working in an area where she was seeing needle stick injuries on a regular basis. She ended up calling the Ministry of Labor, and they did have a workplace inspection, and the inspectors ordered them to transition to safety engineered needles in 3 high-risk areas. But the hospital actually appealed the order, which created a lot of more conflict and a lot of negative media attention as well. So they retracted their appeal and was actually really turned around and developed probably one of the most comprehensive implementation processes compared to the 2 other hospitals. They ended up working with their HSA. They developed a safer field committee. They did a needs assessment. Like the previous hospital, they did encounter some challenges. Their needle stick injuries went down 61%.
comparing the year prior to their transition up until 2011.
Can I just ask, when you have send use as a challenge, what do you mean? That people didn't want to use them, or?
Yeah, that was encountered at all 3 hospitals.
I just didn't know what it meant.
Oh, sorry, yeah. I was going to go through all of them, but
Okay.
I felt that I might be taking a lot of time. But this is specifically not activating safety engineer
Okay,
needles.
so it's just, they just don't want
or taking the safety component off the device.
Right.
And I'll go into that a bit more because it was quite a problem for all 3 hospitals.
Yeah.
Did you say when the regulation came in, and also, I guess, how much warning, when did workplaces become aware of it, and when it did become force?
It was a very long campaign in Ontario, happening over several years. So it would be surprising that a hospital wouldn't know that it was coming. So there was the attempts to try to get the Safe Needles Save Lives Act passed in Parliament, and that was around 2005 to 2006. Then the regulation was established under the Occupational Health and Safety Act, so a different kind of a process, in 2007. Now I would say that other organizations like long-term care were a little bit more aware when they had to transition, which was 2009, because there was a consultation process. So it was a little bit different.
And the act was provincial Parliament?
Yes, it never passed. So the 3rd hospital, this was a large teaching hospital, transitioned starting in 2003, very gradually over time. They had a new leadership in 2003 in their occupational health and safety department, and it was really an interest of this new director to do something with needle stick injury prevention. So they just basically started where needle stick injuries were high, and they slowly over time integrated safety engineered needles. They were able to actually integrate passive safety engineered needles in high risk areas. They didn't encounter any kind of resistance from management or finance. This was something that they were able to do quite easily. And they've had quite a dramatic drop in their needle stick injuries. They only have about a handful each year.
Since they started at different times, that percentage is from like the beginning to the end. You have like a per year,
Like an annual percent? Like an average annual percent decline. Yeah, it's hard to sort of come up with a helpful way to emphasize that, because what's been happening over the last, let's say, 3 years is a plateau, right? So I could, I guess, show it in like a trend in terms of their annual frequency, but I think like an average annual percent decline might not give a good indication.
Or even since the one is like 2007 to 11, you just take the 4 years after the other 2 as well.
Right.
Because since he's counting from 2003, that's an extra few years.
Yeah.
That would add to the percentage.
I guess what the
Like a 4 year after it started.
right. Yeah, I think the challenge is trying to do a comparison and also reflect what's going on in each hospital as well, in terms of when their plateau started and when they observed their decline relative to when they integrated safety engineered needles. And then the challenge is also if they did it gradually or over a 1 year period. So it was interesting to see that, of course, these devices were for the health and safety of frontline workers. It didn't always follow that the devices were immediately accepted and used. So at the first hospital, under the implementation challenges, I talked about physician response. So at this particular hospital, they did have the challenge trying to get physician buy-in to this change. And I think that this particular quote captures this particular challenge, but also the frustration that they had. I do think the doctors were probably one of the biggest. After the staff got used to them, the doctors were probably the biggest problem. And I think they're a little more compliant. There's still some that aren't, though. And I don't know how you fix that. So another informant was able to provide a bit more context around this. The hospital had previously tried to change the suture needles at the hospital, but only for cost purposes, without getting really buy-in from physicians prior to that. And that change never went over. It never ended up happening. So the Director of Health and Safety thought that that previous experience may have influenced how physicians respond to this change and how this may actually be another cost-saving strategy. So I felt that this particular experience that they had really emphasized the importance of communication and also the influence of a past implementation experience. So we were just talking about safer needle use. So all three hospitals had an issue where some frontline workers were not always activating safety needles before sharps disposal or physically taking the safety off the device.
But why? Were they more awkward to use, or why?
Yeah, I mean, I think the next slide captures that really well. But these devices are completely varied in terms of their design, and some of them are found to be a bit more bulky. It's a different feel during the initial transition. So yeah, the next slide will go a little bit more into this, but I just wanted to mention at Hospital A, they also had an issue of, they referred to it as product hoarding, and this is basically what they meant by that. The other issue that does occur, and I'm sure it's occurred in many hospitals, is some staff will try to steal or hoard the old needles, and we have found here and there stashes of non-safety needles that were staff were hiding.
I have a question.
Yeah.
In speaking to the staff that you interviewed, did they mention whether or not they had been part of the purchasing process versus maybe another hospital that actually did have staff being part of the purchase? Like, I'm just wondering, I know one hospital had passive devices, and we've heard that those are the easiest of all devices to use, and certainly, you know, have a better outcome, right?
Right.
So did people give that feedback?
Yeah, in terms of the structure of how they did it, for some hospitals it was very similar to how they would select any kind of new medical technology. All three hospitals did eventually have a safer needle task force. So on the task force, they would have representation from a number of groups in the hospital, typically. But I mean, the hospitals are huge and you have all different groups, so of course, not all frontline workers are involved. And it is a bit of a surprise in some cases.
Do they actually pilot different ones and then take the advice of the group?
Yeah, so what they would typically do is they would select two areas where these new devices would typically be used a lot. And then they would do a pilot evaluation. And this would all be facilitated by the product vendors. So they would go in and facilitate that and do the evaluation and report back to a product selection and evaluation committee. And they would, in some cases, weigh different options based on cost and based on usability, getting frontline worker input on usability.
Let me ask this question. Were passive devices one of the options that were provided to them? Because that may not have necessarily been an option to the task force, right? It could have been two different, one-step devices versus a passive and a one-step.
Yeah.
So do you know if you were able to differentiate that?
Well, I mean, for example, BD has that 3-tier. So there's, one type of procedure, 3 different device options, the manual, a semiotic, and passive device. I don't know specifically whether in all cases they are able to offer frontline workers three different options.
You showed on a different slide what they used.
Oh.
Did you have it up in your chart?
Okay.
That's what they ended up with.
That's what they ended up with.
Oh, okay.
Yeah. So in speaking with purchasing, for example, they did give me the indication that they're trying to respond to the regulation, but also deal with the budget constraints.
That was my concern, is that if someone presents to the task force or to the group that's testing them only 2 of the cheaper versions, that may have an impact then on why we haven't seen such a drastic decline versus the hospital that did introduce passive in the high-risk area.
Right.
I just wanted to confirm the physicians use the needles?
Yeah. Yeah. I mean, not as often as, say, someone working in phlebotomy, but it did impact them. Going on to a theme, important theme I developed to help further this understanding towards this initial resistance, centered around performance. So an important influence in how frontline workers responded to these devices was there was apparent conflict between the changes imposed by the new safety devices and the value shared by frontline workers towards their performance. So what frontline workers were able to really emphasize is that this is not a change to your environment or equipment that you might use occasionally. This is a change to a device that you could potentially be using all day and that you have been using for a number of years. And I think this quote captures that really well. You're taking people who are used to, for example, holding a wing set in a certain way and applying it. And now they're masters of that, and now you're suddenly asking them to use something different, in a different way. And anybody who draws blood for a living will balk against it. So I was able to speak with frontline workers, informants, and also had the opportunity to review incident reports to provide some examples around ongoing needle stick injuries, different pathways in which injury can still occur despite having a safety engineered needle. And there was really three main pathways that were talked about and seen in the incident reports. One being during activation. So this would be unique to the manual devices where you actually have to flip a cap over the needle. So you're actually, in some cases, getting closer to the exposed point. There were ongoing injuries from during a procedure and as a result of patient action. And this was the one pathway I think was captured in that first case report that we saw and was talked about at length amongst frontline workers as being one of their main, where they see injury risk remaining. And then there was also sharps disposal practices. So disposing unactivated devices and having overfilled sharps disposal bins. So frontline workers, informants did use the term learning curve a lot, and it was, in the planning documents. Typically, this is an initial period of poor performance that decreases over time with experience. It was really interesting to see at one hospital they were doing injury surveillance really well, where they were looking at injuries by the time in which they occurred. And you can see that very clearly, needle stick injuries went up during a procedure following the implementation of safety engineered needles before overall declining. But one thing I really wanted to emphasize, and it's really kind of a good news story, is that a lot of this negative feedback, this talk of resistance and activation problems, were often discussed in retrospect. And in all three cases, there was this sort of shared view that issues with safety engineered needles had either been resolved or staff had learned to adapt. And a number of the frontline workers did emphasize the added value of these devices, looking back, and how they actually can reduce injury risk dramatically. So I'm not going to go over some implementation facilitators just based on the time, but I'm happy to talk about that because that was a really interesting outcome of this study. So I was really interested in ongoing integration efforts, what's currently being done by hospitals to bring injury rates down further and make additional improvements in technology. So 2 of the hospitals were continuing to see needle stick injuries. There was a plateau, and they did have interest in bringing those down further. It was really just the one hospital that was only having a handful each year. Only one hospital was looking at their exceptions, so where non-safety needles were being used because of an exception under the regulation. There just wasn't a safety product out there. In terms of product improvement, Hospital A actually had to make a switch. They had a device that actually was described as a non-functional safety. Workers were not using it, they weren't activating it, and injuries were ongoing. And they did replace that device, but upon widespread rollout, there were additional issues with the new device. People felt they weren't consulted, it was more awkward to use, they didn't get flashback. So it was described as a poor rollout. But there was that one hospital that integrated passive safety engineered needles, so there was some movement there in terms of product improvement. And there was still practice issues talked about, so still accounts of my coworker doesn't activate the safety devices always. People are not activating at the right time. There was still some of those reports. A lot of the ongoing activities were very much reactive in nature. So a newsletter would have a blurb about needle stick injury prevention, or there would be an email sent out when needle stick injuries would spike up. But there wasn't necessarily anything ongoing to really reinforce training or education or raise awareness at this point in time. So I talked before about this change commitment in the organizational readiness for change. And the question is, do organizational members perceive the change to be needed, beneficial, or worthwhile. So there was apprehension about the value of future investments to promote consistent quality use of these devices and the need to enhance the current stock of safety devices for sure. And frontline workers, it was really surprising to me that a number of them were not even aware that injuries were ongoing. So if they didn't have a personal experience, they didn't even know that needlestick injuries were continuing to be reported. And there was different perspectives over whether ongoing injuries mattered and what should be done about it. So specifically regarding the move to passive safety engineered devices, so this would actually influence whether people, where do they think ongoing injury risk, where is it, and what can be done. There was, a shared belief that ongoing injury risk is largely due to individual practice. So, reflected well in this quote, at the end of the day, the issue isn't what the hospital has, the issue is how staff uses it. So a number of...
Was that a widespread belief then?
Nope,
No.
they were divergent.
Okay.
There were divergent perspectives, but this was one of the perspectives.
Yes.
Yeah, for sure. So that was reflected in saying things like staff need to be more careful, they need to take control over the situation, not to rush through a procedure.
Sorry, did you say, and this was with regard to passive devices? Or just generally?
Generally. With passive safety devices, you really kind of have less latitude of whether to decide to activate or not activate because it happens automatically. So
It would almost be more from a clean needle.
exactly.
Yeah.
But this is what I wanted to emphasize with this. There was alternative views presented as well in talking with frontline workers and informants. There was talk about, and I don't mention this here, but things like workload demands. So not necessarily individual, need to improve individual practice, but also the environment and working conditions. But what was so interesting is that it was really the frontline workers who had recently had a needlestick injury that were the most passionate about safety engineered devices, and specifically passive safety engineered needles, providing very step-by-step detailed accounts of how they felt their injury experience could have been prevented had a passive safety needle been available. And it was really helpful to have some of these workers bring in needles to the interview to show me the difference between a manual device and a passive device, or a semi-automatic device. I also wanted to emphasize that there's also this part about change efficacy. And there were a number of frontline workers and informants who did talk about, we don't really hear anything about needlestick injury prevention. Nobody identified needlestick injury prevention as an ongoing priority. And there was also lots of talk about cost, the cost factor, available financial resources. And it really influenced some frontline workers and whether they thought they would actually make a recommendation. And I think it's really reflected well in this quote. A retractable would be better. It's a much higher cost right now, and everybody's cutting so much, but I can't imagine them bringing anything more in. So this theme that I developed, I actually initially called it change overload. It was an explanation for how frontline workers and informants talked about the initial transition and the challenges that were encountered, but also in how informants seemed to talk about whether or not they would invest in future changes. But I actually found in the literature, it's called change fatigue, and it's actually been really well developed and talked about most recently in nursing practice. And I think it's really well reflected in this particular quote. Hospitals are going through so much change right now universally that people are almost resisting anything. I mean, not just making an argument for the sake of arguing, but people are fed up in the current state, just get a little fed up with change. So I think that's confounding what they really feel about the product or its safety. If it's something different, it's a change and then they don't want it. So I hope that those insights, those specific insights from the study have provided a bit of context about why we might be here at this point and not here, and also some of the challenges that we need to take into consideration in trying to get needlestick injury prevention down further and raise the importance of prevention. So I have a summary of all the stuff that I covered. Injury trends in Ontario have demonstrated that needlestick injuries have declined, but the decline hasn't been substantial. All 3 hospitals under study responded with integrity, but there was evidence of inconsistent implementation and outcomes from the transition. And there was a conflict between the values healthcare workers place on their performance and patient care and the learning curve associated with the initial transition. A lot of the ongoing activities that were in place, if there were ongoing activities, were very much reactive in nature and actually really relying on injury data, which, as many of us know, is very subject to underreporting. And then I went through some of the challenges that might impede further progress in needlestick injury prevention and things we have to think about. One was the lack of awareness of ongoing injury risk, different views regarding how to address ongoing injury risk, whether additional investment would be worthwhile, variations in perception as to what should be changed. Should we make a change to the devices, to the environment, to training, and influenced by progress reliant on financial constraints and other priorities. At this point, I did identify some specific things that could be done in these types of hospitals where they are observing a plateau, where they may not be able to make a large investment in terms of enhancing their safer needle technology. It seemed like there could be something going on to really increase awareness regarding ongoing injury risk. Root cause analysis to identify what measures can be taken to reduce injury risk, to actually look at in more detail the incident reports and to track what devices are causing ongoing injuries, what areas. I identified this need to enhance surveillance efforts at the system level. I mean, we do have these 2 administrative data sources that can look at trends over time, but I mean, to monitor the impact of a regulatory standard, of course, we do need better surveillance data. There's also seems to be an opportunity to continue to enhance safer needle technology. And then in terms of research, I really did find this role of professional values, workload demands, change fatigue on the implementation of health and safety interventions to be quite interesting and could be developed further. And I think there also could be done some more work around the efficacy of passive safety engineered needles if we want to push that forward.